Kia ora and kaya. Welcome to today's AIPPEN session. My name is Heidi Waldron, and along with Dr. Megan Anakin, and we are representatives of the AIPPEN Steering Committee, and we are your hosts for today's session. As we begin, on behalf of AIPPEN and ANZAPPE, I acknowledge and pay respect to the traditional owners, custodians and knowledge holders of the lands and waters across Australia on which our members live and work, and to the elders past, present and future. I join you from Wajak Budja in Perth, Western Australia. AIPPEN and ANZAPPE also acknowledge Māori as tangata whenua and Te Tiriti o Waitangi partners in Aotearoa, New Zealand. I invite you to introduce yourself and make any acknowledgements you feel are appropriate using the chat function of Zoom. Please ensure your first and last name are visible on your tile. If you're an AIPPEN member, please add IPE after your name, or if you're an ANZAPPE member, please add ANZ after your name. This will help us assign a good mix of people to the breakout rooms. I advise you that this event is being recorded. Please turn off your video if you wish. However, I do encourage you to turn on your video in the breakout rooms. The conversations in the breakout rooms will not be recorded. If there are two of you joining on the same tile, please check that your name is correct and list both of your names to help people to communicate with you. I do encourage you to use the chat function to post comments and questions throughout the session today, because of the goal of this networking series is to encourage conversations between people interested in interprofessional education to exchange ideas and share practice. Now, I'm very delighted to introduce you to today's session and today's guest speaker. The session is titled Propelling Rural IPE Research, and I'm delighted to introduce Dr. Priya Martin. Priya is an occupational therapist and health services researcher who worked in industry for 18 years before moving across to academia in 2021. She's worked in several clinical, project management, education, research and training roles in Australia and overseas, and outside major metropolitan areas. She's a member of the AIPPEN Steering Committee and Interprofessional Global's Global Impact Research Group. She received the Barbara Brandt Best Research Award from Interprofessional Research Global in 2021, and Expertscape places Priya as Australia's fourth leading IPE CP, which is Interprofessional Education and Collaborative Practice researcher. She collaborates with researchers worldwide to undertake her research and scholarship, and many of you will have no doubt had the privilege of seeing Priya in action at our most recent ANZAPPE conference. Today, we anticipate that you'll leave with at least one idea to explore, and also the opportunity to broaden your network of colleagues who share your interest in interprofessional education. Okay, over to you, Priya.
Thanks so much, Heidi. Thanks everybody for being here. The lighting in the room I'm in today at the moment is a bit low, but you've got a photo of this so you know what I look like. This is just a little bit of career context about my career and how my interest in IPE and CP, interprofessional education and collaborative practice, research and scholarship started. I moved to Australia from India around 2008, working in clinical and clinical education roles. And my first IPE role was with Queensland Health. I held that for about 10 years while also doing a part-time PhD and having kids and all of that. And around 2021, I moved over to the University of Queensland, which is in my current role, undertaking research. We heard about the Barbara Brandt Award. You can see a little for it. I've got that in there because I'm going to talk about that project as a case study later on. So I've got that there for those reasons. And it's been a real privilege to have had all the collaborators that I continue to work with in the IPE-CP space and all the different mentors I've had the privilege of being mentored by and who have helped me with my journey in this space. So talking about rural IPE, I really think of that as undertaking IPE, and I'm using the terms IPE and IPCP today to mean in an interchanging sort of way for this presentation. Undertaking that in resource-constrained environments, I think, is what sums up undertaking IP in a rural environment, because a lot of times it's short of resources, it's has human resource constraints, there's workforce turnover, you've got to do more with less, in a lot of rural health settings. All my career, I've only ever worked in regional and rural outside metropolitan locations in a couple of different countries and in different health services. And that's sort of been my experience. So what I thought I might do is we might start broad, have a look at the global international literature, the most recent in terms of what are some of the barriers and enablers of IPECP in general for everybody. And then we might look at rural Australia, and I'll share a bit about some literature reviews that we've undertaken. And I'll also provide a case study as an example that's the RIPES project that I'm going to talk about, and share some insights from my experience. So this is a report that a lot of you would be familiar with. It's the Global IPE Situational Analysis Report from 2022. It's on the Interprofessional Research Global webpage, just off Google. And it was a 17-item survey that also had open text responses that was sent out across the world. 152 academic institutes from 6 regions in the world participated. Just about half of those reported having established IPE programs. The highest were in USA and Canada. Australian responses were low, and they were quite similar to the summary responses I've got here. Half of IPE programs across the world are less than 5 years old, so it shows sort of the field still is new or emerging in some areas. 1/3 of institutes have no formal IPE leadership role, 1/3 have no dedicated funding for IPE, and participants talked about need for dedicated IPE space, time, and resources. So that's at the global level. When looking at the barriers and enablers that are specific from that report, people talked about time, high workloads, lack of funding, tribalism and hegemony, dominance of some professions, lack of IP champions or dedicated staff, and lack of recognition of IP for promotion. So sometimes in research, when you're an IP researcher, sometimes, and I've experienced this, you're not seen as being at par with, some other things maybe. In terms of what people wanted to see more of, they talked about collaboration between organizations, student and consumer engagement in IPECP research and scholarship, faculty development initiative, and the report called for more evaluation, assessment, and research of IP programs because that was seen to be lacking. So this is sort of the global landscape. I've just flagged here one of my recent papers I did with some international collaborators, and this is a review we undertook on consumer engagement in IPECP. So because this is one of the things the report has flagged, so I'm just flagging with people that want to read up more on how to engage consumers in IPECP research, practice, or training. You might want to have a look at this one. So the next part of the presentation, I'm moving into findings from a regional Queensland survey. I may have skipped a slide. Yeah. So this is just, so I'm drilling down now. We've had a look at the global scenario, and now I want to give you some insights from regional Queensland, where I worked for many years. So we conducted a survey in 2019 that's going to be published as an upcoming 4-page paper, so keep an eye out for it. There are 2 health services that we went to, and they all sat between modified Monash 2 to 7 sites, so regional to very remote. And healthcare workers perceive knowledge, understanding, skills, and confidence in IPECP, and their preparedness to facilitate IPECP is what we investigated. It was a mixed method survey, and we had about 235 respondents, which sounds like a good number, but it wasn't a good response rate. The response rate was only around 5%, which is quite low. As you can see, we had respondents from nursing, allied health medicine. OT was the largest profession that responded within the allied health group. So and the key findings were that only 6% had formal IPECP training. more recent graduates scored better, and because they had IPE through the university as they trained to become a healthcare worker. And there was a lot of frustration that people had expressed in that survey through the open text comments. Lack of awareness of terms, concepts, and frameworks had frustrated people. We did some multiple regression analysis, to see what things would predict a high knowledge of IPECP, just depending on the scoring the survey generated. Those that understood the difference between different service delivery models, like, what's multidisciplinary versus interprofessional versus transdisciplinary. So someone that understood all of those different sorts of models, they had higher knowledge of IPECP. Those that had an ability to explain IPE to a colleague, then they had a better knowledge. And being an allied health professional, and this is not a term we like to use in the IPE world, but just for the purpose of showing that that group, in comparison to the medical or the nursing colleagues, had a better knowledge of IPECP. I'm just going to share one of the quotes we got from the free text comments, which actually sums up all the frustration people were experiencing just from the lack of awareness of what all of this is. Someone had said, "What are you talking about? I've never heard of it before. I have no idea." And this is all the same person. I don't know. I don't fully understand the concept. It's a new terminology, buzzword, or 5-letter acronym. So this was just one of the many comments that I received of this nature in this survey. So that was from 2019, though. I'd like to think the fields evolved, and there's probably a bit more that's happened, and people have caught up. So this is a literature review. So this is the next part of my presentation. We started off doing a literature review. So this is the most recent literature. We wanted to look at what were the enablers and barriers of rural IPECP initiatives, only because we've been talking, and there's lots of good, either quality assurance activities or research activities that happen in the IPECP space in the rural environment, but not all of them go through to the reporting stage. And we wanted to see what were the barriers, what was stopping people, from completing that process. So, which is what we mean by practice research integration. So we started the review off, and just could not locate enough number of relevant studies. It just felt like a very stringent criteria. So we had to expand the question, and then we said, let's look at all of the IPECP initiatives that have been undertaken in rural healthcare settings. This is an international literature review. And then we included all healthcare workers, any initiative in a rural healthcare setting, all designs, and in the last 10 years, we searched 3 databases and followed the World Health Organization and Cochrane guidelines. Had about 2,530 studies, citations that we could import into Covidence, and we included 43 that met criteria. I've got a couple of medical students who may be online today that I wanted to acknowledge, Arkam and Nantika, who've been helping with the review, but we've got a broader team as well behind this. So we can share with you some preliminary findings. We've just completed data extraction, and we've looked at what the enablers and barriers are looking like for rural IPECP. It's very similar to what we looked at in the global IP situational analysis report. So in terms of the enabler, I think the biggest enabler actually is the rural environment for collaboration. So people are saying it's a smaller team. We've got to work closely. We've got to use these resources. So, we tend to be collaborative. So that's the common sentiment. And if you specifically see what the students are saying, the support and supervision they get during placement, and the students that actually had made a choice to go rural, they were the ones that actually find those as enabling factors, in completing an IPECP initiative. The barriers were similar, it's the time and the logistics in terms of scheduling multiple professions, small sample sizes in the research studies. So it's really hard to, generalize or to have, to make a lot of conclusions. And then researchers said it's hard to link outcomes to IPECP alone because, that's the nature of the field of research, and you have to be put so much thought into the methodology, and it's really hard. Like, it's not like you can go in and do a randomized control trial and then isolate and put that, unless, it's there's a lot of factors that go with it, and funding as well. One of the examples I want to share before finishing off my section is the RIPES model. So this is the case study just from my own experience. There is a presentation about this model on YouTube, but I'll also put in a plug that I'm presenting about RIPES at the upcoming IPE showcase in Auckland in November, the Combined Universities showcase. So I'll be presenting just on this model. It was, this project took us more than 5 years to do. And what basically happened was it was a faith study, but in a nutshell, we had coordinated student placements so that students from more than 2 professions, so that was the minimum, were undertaking placement at the same time and at least for 5 weeks of overlap. So we call this the Rural Interprofessional and Supervision Model, and it was a Queensland Health UQ partnership. So there was both IPE components and interprofessional supervision components. These were the different health services we went to. So we had a total of 6 sites. It was a quantitative and a qualitative analysis. So we had both components. The quantitative findings showed that the RIPES model resulted in significant change in student IPE perceptions and attitudes following the RIPES placement. So we compared it to regular placement models. We compared it to placement conditions. I won't go into the details, but the RIPES model didn't take students away from their clinical or patient contact time. And the qualitative component showed it was beneficial to students, supervisors, and workplaces. My reflections about RIPES, because I started this when I was in my Queensland Health role, it went through the pandemic, and then I only finished off the reporting. We finished off the reporting only like quite recently. We have had about 6 papers come out of it, which you can look up. But the challenges were real, and there were many. It was quite hard to progress it to completion because of funding, the leadership changes in the organizations, the policies and priorities changed. There was staff turnover. I went on maternity leave. I had to come back early so that the project wouldn't fall, and the pandemic and all sorts of things. But we also had enablers, which is why we could complete the project. We had grants, we had persistence. Our research team was intersectoral. We had IPCP champions and advocates, which is why we completed. But post me leaving that role, no one else has been able to take that on. So the model actually has sort of died, maybe integrated components of it integrated into other things, so the sustainability, I'm just not sure what the future looks like, although we know it's a tried and tested model and it was useful. I've just got my ResearchGate handle there if people want to look up publications on RIPES or the other things I've mentioned, but equally feel free to email me if there's anything specific I can share with you. I want to leave the breakout rooms with 2 questions. How can we leverage enablers to tackle the barriers to enhance IPECP in rural healthcare settings? And what can improve sustainability of IPECP initiatives? Because sustainability keeps coming up as one of the issues or challenges we face in this field. So that's just another thing that would be good to consider.
Wonderful. Thank you, Priya. I'm inspired and looking forward to having some conversations in the breakout room myself, especially about ideas about how to encourage students to go rural as one of your primary enablers jumped out at me, and I'm sure that everyone else has got different things that resonated for them. Thank you. In a moment, everyone will be invited to join a breakout room to discuss these questions that are placed into the chat. And you'll have at least one AIPPEN steering committee member or an ANZIPE fellow in the room to help ensure that you have a rich discussion. So when you join the room, please briefly introduce yourself to each other, say your name so that we can pronounce it correctly, where you work and your interest or experience with interprofessional before you start to discuss Priya's questions. Priya will share some insights from her room, and we invite you to also put any insights from your own room into the chat as you go. Welcome back, everyone, to the main room. I'm sure that you enjoyed your conversations. I felt like we're only just getting started in ours in many respects, but we had some wonderful ideas prompted by Priya's talk. I'd now like to pass back to Priya to share some insights that were gained in her room, and invite the rest of you as you listen along, if you would like to share comments from your room in the chat room.
Thanks so much, Heidi. And I agree. We had a really good discussion, and you were right about the time not being enough. There's just, I think, people bring such rich experiences and valuable conversations, and yeah, we kept going. And the main gist of the things we discussed was, I think all of us agree that we need more evidence from IPECP research, more proof that IPECP is worth the money and it has those clinical impacts, and it's making a difference. So that's something that I think just needs to progress more. And we talked about sometimes the university sector might prepare students in IPE and get them ready, and then they enter the practice setting. And those that have worked in practice settings, probably can relate to this quite well. Or recent graduates yourself, you get into the practice setting and you're like, this setting is actually not ready. This team is not a collaborative team, or this environment is not ready for me to practice interprofessionally. So there's that mismatch or a gap, which we've always identified and we've been talking about. Or when they are undertaking placements, it's hard for them to implement those things. So we've talked about organizational leaderships and policies, and what sorts of things can actually influence that, and look at the bottlenecks. But one of our participants also talked about how, as a UDRH, they're looking at some mining partners within their community that might give out student bursaries to attract more students to come and do those placements where they can engage in IPE. So just thinking more broadly, working across sectors. We also talked about, UDRH, for example, they may be really good places where there's students from lots of different professions undertaking placements and they're learning. But sometimes if it's not set up to promote IPE and IPECP, it might be hard. If it was set up for, profession-focused practice, maybe. And if it's not an IPECP model right from the start, it might be harder to know it. So, the newer units that are coming up, that might be a good idea, is to, right from the start, think of how can I set this up so that it can facilitate IP and IPECP. And we also talked about, some barriers for IPECP placements when, you want to, like the RIPES model, and other models that people have tried. The scheduling and the logistics is really hard to negotiate because different universities and different professions, they start their placements at different times. So if you want to get students from different professions on placement at the same time, it's a lot of individual negotiations. And some professions will be flexible, some universities will be flexible, some won't. So that's a real barrier. And what can we do? How can we break those barriers down? And also, one of the participants talked about when you are running an IP model, even that's quite applicable to RIPES, and you're looking at supervision coming from another profession outside of the student's profession, there can be lots of barriers around that, and how do you go about? And some professions may not want the student to be supervised from this other profession if it's not their own profession. So it's how do you set that up? We talked about service learning models and telesupervision for rural sites. And again, if they're off-site in another location, but their supervisor is not with them, or they have someone from another profession, how are we going to make all of that work? Again, how do you build a case and show it's effective? I think at the end, we all agreed that IP is very important. And we really need that for preparing collaborative practice-ready graduates. So, it's something that needs to be done. And rural places, in places like UDRHs, they're ideal environments. But I guess it's just having more conversations about where are those bottlenecks, what are those barriers, how can we learn from other people that have done it, or what can we follow from other examples we've seen and implementing. Heidi, that was a quick summary of our discussion.
Wonderful. Thank you so much, Priya. I'm seeing from all of the chat and also the discussion that I was privileged to join in our breakout room that this is a really important topic, and that there's a lot of, I think there's a lot of resonance about the challenges, the enablers, the importance of champions. I'm really looking forward to hearing more about your research as it's published in the journal. Some people will be fortunate to go to Auckland upcoming, and you know, I hope you get to see Priya presenting there. So thank you very much for your guiding of the session today, and for inspiring some really lovely connection between different people who share the enthusiasm and, I would say, are champions in this space, as well as also planting some seeds for some ideas that we can maybe take forward as well. We do have an evaluation link that we will share in just a moment. We value your feedback so that we can basically ensure that we keep these sessions focused towards what our members would love to hear. And this was a recommendation for today's session. And so I thank you, Priya, for being able to guide something that our members deeply value. So please take the opportunity to fill out this very brief survey that we will send. Megan's put the link in at the moment. We have got a couple of other events coming up that will just quickly signpost for you. They are ANZIP events. There's a masterclass on 19th of October about how to embed empathy and compassion into your learning environment. And there's one on 16th of November about how do I increase my chance of getting published. So all important things as we lead into the end of the year and we're planning for next academic year for those in the university setting. And, you know, especially the first one is relevant for all educational settings. So I thank you for joining us today. I thank Kendall for doing a wonderful job again of guiding us and sending us all to the breakout rooms, and so much more than that as well. I thank Priya for being involved, and Megan Anakin for also being a co-host and a great support in this series. We do plan to have future events next year, and we will let you know via the email methods and also via the website about what those events will be. So thank you, and you now have 10 minutes to get to your next event, and you can tell that we're educators at heart. So have a good day or good afternoon, everyone.